Hello, and welcome to Zufall Health and Delta Dental's continuing dental education series. My name is Dr. Antonella Mayetta, and I am one of the lead dentists for Zufall Health Center. I will be moderating today's course. Before we get started, I would like to run through some housekeeping items. All guests join our webinar on mute. We encourage you to ask questions to today's speaker, Dr. Jade Duncan, through the Q&A box. All questions will be held until the end of the presentation. Be sure your Zoom display name is your own name so we can verify your attendance in the webinar. To receive CDE credit, please remember to complete the evaluation at the end of the presentation. The link to complete the evaluation will be posted to our CDE page at zufallhealth.org/CDE. The evaluation will remain open for 1 week after the course. Once the survey is closed, CDE certificates will be issued to participants. There will be a delay processing the CDE certificates due to the upcoming holiday, and we thank you for your patience. You will also find links to register for upcoming courses at zufallhealth.org/CDE. You can register for our future courses by visiting that page. We also display our past courses here. After the course ends, you'll find a survey below Dr. Duncan's name on our CDE webpage. Again, this evaluation will be open for 1 week. Your certificate will be sent to you in the following 2 to 3 weeks. Now for a little bit about Zufall Health Center for anyone who is new to our organization. Zufall Health is a federally qualified health center in Northwest and Central New Jersey. We have been serving patients for over 30 years, and we were founded in 1990 by Dr. Bob Zufall and his wife, Catherine, pictured here in front of our dental office in Dover. In 2023, we treated close to 48,000 underserved patients across 7 counties in the state. We want to give a big thank you to our CDE series sponsor, Delta Dental. They have been a longtime partner of Zufall, supporting our Zufall Health Delta Dental mobile unit, as well as our Smiles for Our Heroes event that provides dental services to low-income veterans. They've also been supporters of our beautiful new clinic space in West Orange that opened earlier this year. And our dental assistant training program provides on-the-job training to participants right here at Zufall to help us address critical gaps in the dental workplace. We have a few opportunities for how you can get involved with Zufall. We are looking for volunteer providers for Smiles for Our Heroes to provide dental services to our veterans. You can email my colleague, Afa Falawani, if you are interested in being a clinical volunteer. And we always welcome your financial support. You can make a tax-deductible contribution to us through our foundation at zufallhealthfoundation.org/donate to support access to health care for our underserved patients. And now, for the reason why you've joined us tonight, I'd like to introduce Zufall Health's Dr. Jade Duncan. Jade Duncan is Senior Vice President of Dental Services at Zufall Health. She's a native of Trinidad and Tobago. Duncan is an experienced community health center dental leader. Her background blends clinical care, curriculum development, and people management. Prior to joining Zufall, she served as the Director of Dental Residency for the Advanced Education in General Dentistry Residency Program at Penobscot Community Healthcare, a federally qualified health center in Bangor, Maine, where she generated a 15-fold increase in applications to the program. She concurrently served as the co-lead project manager of Diversity, Equity, Inclusion, and Belonging at the health center. Duncan earned her Doctor of Dental Surgery degree from the Howard University College of Dentistry and completed a general practice residency at Bronx-Lebanon Hospital Center, where she was chief resident. She also earned master's degrees in both business administration and education from the University of Cincinnati. Additionally, she graduated with a certificate in theology from the E.L.I. Bible Institute and Seminary. She is currently enrolled in a Master of Legal Studies program in healthcare law from the University of Oklahoma. Dr. Duncan, I'll turn it over to you now. Thank you so much.
Hello, everyone. Thank you so much, Dr. Mayetta.
Of course.
I am just going to get started. I'm going to share my screen. All right. So I am so excited to have so many of you join us today. Good evening, everyone. I am genuinely impressed to see so many of you here on a Wednesday evening for a lecture on complete dentures. Let's be honest, complete dentures aren't exactly the most thrilling topic, and I get it. Many of us find that these procedures are less than enjoyable for various reasons. So tonight, I'm going to try to change that a little bit. I mean, most of the times it's because we don't feel very confident in what we're doing. So I think if we just learn a little bit more or refresh our memories. I know some of us remember from dental school, these were snooze fest lectures. So I would not be offended if you fall asleep. Just make sure that you keep your computer screens on so you can get your CE credit, okay? All right, so let's just dive in. At the end, we will be providing a link to the presentation slides, so you can have that, as well as a great article that you can reference. All right. So today we're going to talk about the most frequent issues reported by patients who are wearing complete dentures. We want to understand the techniques to assess the root causes of common denture-related problems and implement some practical strategies and evidence-based interventions to effectively troubleshoot and solve some of these problems. I included a picture of one of the most difficult denture cases that I did. I think I did this case maybe about 12 years ago. This patient had a crossbite, a deep bite, but a class 3 bite. This was one of those denture cases that just left you scratching your head. So I just thought it was pretty cool to include some pictures of this during a denture lecture. So when it comes to treatment planning or troubleshooting or trying to come up with a way in which you can help your patient after they reveal some sort of post insertion problem or complaint, or you notice something during your delivery of the denture, the most important thing is really to listen to the patient. In making the denture, listen to the patient, because you realize that a lot of the issues that you encounter could have been avoided by just doing a really thorough exam, you know, and making sure that the patient is a good candidate for complete dentures. And I know some of us who work in more community health settings or in areas where patients have no choice but these options, especially based on their insurances. We sometimes have to do these versus like implants or something more fixed. So really taking a good comprehensive history will be very helpful. And most of the times you'll realize that the solution is housed in the nature of the complaint. And by just listening to what the patient has to say, it can be an easy fix. Instead of you just grinding everything down. Sometimes when the patient has a specific complaint, it's just going to be a keyword for you to investigate certain issues. And we're going to talk about some of those keywords or some of those common problems or symptoms that you find clinically as well, and how we can fix them. So let's talk about some post-insertion problems. So some of the most common ones are looseness, discomfort, poor appearance, speech problems, difficulty eating, clattering of the teeth during eating and speaking, and nausea and gagging. So I am not going to assume that all of us remember all of the names and the technical names of the parts of the denture. So I'm just going to do a brief refresher so that we can all be on the same page. So when I use some of these terms during this talk, it makes some sense. So there are three main components or denture surfaces of complete dentures. You have the impression or the intaglio surface, the polished or the external or cameo surface of the denture, and the occlusal surfaces, right? So in this slide, I include a couple of images. So here you know that there's the occlusal surfaces, right? The occlusal surface of the teeth, that's a pretty straightforward thing. So on the outer or external surfaces, this is your polished surface area, okay? Your impression surface, if you hear me say an impression surface or intaglio surface, it's the inside, the inner surface of the denture. And then if you hear me say periphery or denture border, it is the borders of the dentures, right? And then also we're going to talk about denture flanges. This is your lingual flange. That is the area, the polished surface area, lingual to your denture. Then you have the labial flange. That is the area of the denture that contacts the inside of your upper and lower lips. And then you have the buccal flanges, and that's what contacts your buccal surfaces in the inside of your cheeks, right? Then you're going to talk about the different areas. We're going to talk about under relief or overextension and things like that. We're talking about these notches where you'll have your frenum attachments or your muscular attachments. So just a brief overview here. So I'll also talk about some denture adjustment materials. You'll hear me talk about disclosing material or PIP paste. The disclosing materials, this is a image of PIP paste. I know some of you guys use this already. There's also Hydent, okay? And then in addition to that, we have the denture adjustment burrs or your acrylic burrs. You have your horseshoe acrylic, your horseshoe articulating paper. And then we have the good old lathe and buffs. And I know a lot of us have these in our practices, our offices, our clinics, and it's just there collecting dust. It's not a paperweight. They do serve a purpose. Every time we adjust the patient's denture, we should be polishing those polished surfaces again. It matters. It makes a difference. This machine exists for a reason, and we should be using it every day if we do dentures. So we will talk a little bit about that. So we're going to start talking about patients' complaints surrounding discomfort, especially on the impression surfaces. That's the intaglio surface. So that's the surface on the inner side of the denture, if you remember from 2 slides ago. The first complaint you would hear is, you know, doc, it hurts right here, and they point to a particular area, a discrete painful area. You want to check immediately if there's any pulls or sharp ridges of the acrylic on that intaglio surface. Sometimes in the laboratory, some stone may have gotten trapped in there, some plaster, or even an air bubble that grows to the surface, and it may not be seen to your naked eye. So, but it can feel really rough to your patient's tissues. So what you want to try to do is take your finger and kind of rub it around until if you feel anything, or you can take like a cotton ball and then kind of just drag it, a dry cotton ball, and drag it along the intaglio surface. And if it snags, those are the areas you reduce. You could also use disclosing material like PIP or Hydent. And if the patient has any like knife edge areas after we reduce the heck out of the denture flanges and the borders, then in that case, you want to do at least a soft liner to cushion the impact of the knife edge. If the patient is complaining of pain on insertion and removal, and you notice some inflamed mucosa on the ridges, there's most likely some denture undercuts. So you want to use disclosing material to adjust the wipe off region. So basically the areas that the PIP paste is removed when the denture is going in and out. And you want to make sure you're the one moving the denture in and out to ensure that there's no premature occluding that's happening when the patient is doing it, so that you get a more accurate reading from the PIP paste. And you want to make sure that you're adjusting the first point of wipe off, so that, because obviously there's an undercut, so as soon as you engage it, it's going to wipe everything else. So you don't want to go drilling all of it down. You want to start at that line and start adjusting that area bit by bit until the patient feels a lot more comfortable in taking it on and off while keeping the retention. Patients will complain about pressure areas, painful to pressure. That's usually if there's some sort of a warping in the processing of the denture. That's usually an issue with the lab. Usually the denture is perfect all along until the very last time when they're casting it. So it could have been some damage to the cast, an inaccurate impression. Maybe your impression wasn't that great, and maybe there's some sort of retained root, a tori, or some sort of a bony specule that could just be rubbing that area. So again, PIP paste will be your best friend. And if you notice that it's not being relieved by that, you may want to remake the denture. It's always an option. But if you notice that, oh, maybe there's a root here, you may want to consider removal of the root. Then the other thing you'll hear is that when they protrude their tongue, they stick their tongue out, the denture lifts up, or that they have pain on swallowing. It could, and also the mylohyoid ridge area it feels painful. They point in that area. It's usually an overextension of your lower impression. So when you took your impression and you did the border molding of your tray, you didn't reduce the areas of the border molding before taking the final impression. So you created a very, very deep sulcus impression. So that's what causes that overextension. We have to remember we do need to reduce that after you do your beautiful border molding. Reduce it a little bit so that you leave room for the impression to make up the rest of that space. Then the patient will just say, you know what, doc, it hurts everywhere. All underneath here, everywhere hurts. And that's usually an under extension of the denture base and usually a violation of freeway space. That may sound like a foreign word to some of us who've been out of school for a while. So just a reminder, the freeway space is the difference between your VDO, your vertical dimension of rest minus your vertical dimension of occlusion. And if you didn't know, it's usually between 2 to 4 millimeters. So you want to make sure that when you're doing that, that you're not violating the freeway space. That will cause real pain and painful areas to pressure when the patient is biting, and really cause it to not sit properly. Okay. So you want to go ahead and border mold again and extend the area of the denture and get that remade. And if there's insufficient freeway space, the only thing you can do is remake the denture. Not much cheat points that you can do for that. It's just, you're just going to have to do it over. So if you have any areas, for example, in the notches where there's not enough release for the frenum attachments, the muscle attachments, or you feel like the tissues are pinching between the denture and the mouth, or patient is complaining of a sore throat, and again, sore throat combined with difficulty swallowing, you want to look at the borders being overextended again, but usually in the impression stage, or there's some error in your design. And usually there's some palatal soreness. If your posterior palatal seal, the dam is too deep and it's sticking into the patient's palate. So again, you want to use some PIP paste. You want to take care adjusting the posterior palatal dam. You don't want to under reduce it and then create a lack of retention. And that's a whole brand new problem that you're going to create for yourself. So you want to be real careful. But if you aren't sure and you're not really getting any relief, you may just want to knock out the whole the whole seal and then redo it with some compound and send it to the lab to get it remade in acrylic. Hope you guys are holding in there with me. This is again a really wordy topic with a lot of words, a lot of stuff. But I promise you stick with me. You know, you're gonna learn something, and if not, you'll get the slides and you can learn it tomorrow. And for the things you don't understand, you can Google. So we're gonna talk about areas of discomfort on the occlusal and the polished surfaces of the tooth, of dentures. Patient is going to complain about pain on eating in the presence of an occlusal imbalance. So the patient is trying to chew, and then the dentures are rocking. So they bite into the front, the dentures are rocking to the back. They bite into one side, the dentures lift up on the other side, and it's just rocking. There's usually a prematurity somewhere where the teeth are having a premature occlusion, or there's some sort of incisal locking that's happening between the upper and lower incisors, and obviously a lack of balance articulation when the casts were mounted. So you want to determine where the occlusal prematurities exist, and you want to adjust occlusion by selective grinding. So let me talk a little bit about selective grinding, because I think sometimes we just grind everything that looks like a heavy occlusion happens. That's not how you adjust dentures. You really have to be careful, and you really want to make sure that you are grinding following the 4 main rules of selective grinding. Number 1, you never want to grind a centric cusp tip if it contacts prematurely. If it contacts prematurely in all of the patient's excursive movements, you want to adjust the opposing fossa, right? So the area in which it contacts in the fossa of the opposing teeth, that's what you want to adjust. You do not want to start grinding down the first thing, the cusp tips, because then you're going to end up with a flat occlusion, and you're going to have an even more difficult time, right? You're going to be reducing the VDO, and you're going to have a lot of issues. So you want to make sure that adjust the fossas first, not the cusp tips. Okay. You want to use the bull rule, which is grind the lingual incline of the incline planes of the buccal cusps of the upper teeth, or the buccal incline plane of the lingual cusps of the lower teeth. Also, the third rule is if there's a premature contact on the balancing side, then you want to adjust the buccal incline plane of the lingual cusps of the upper teeth, or the lingual incline plane of the buccal cusps of the lower teeth. I know it's a lot, but these are the rules you need to follow if you want the dentures to be well. We can't just go grinding everything, right? And then the fourth is if you're trying to correct protrusive interference, then you want to make sure you're adjusting the labial portion of the incisal edges of the mandibular teeth and the lingual portion of the maxillary teeth. So you're not grinding the incisal edges, right? You know that little angle, that's where you're adjusting, right? So you want to be really, really careful so you're not reducing and then causing space between the front teeth, okay? All right, so let's get back to the rest of it. So pain lingual to the lower anterior ridge. If you don't see any overextension, then you want to look for a protrusive slide from RCP to ICP. Don't worry if you don't remember what it is. RCP is your retruded contact position, and ICP is intercuspal position, okay? Treatment, you want to mark deflecting inclines of posterior teeth with a thin articulating paper. And if slide exceeds half a cusp width, then you want to re-register and reset the teeth, right? So if it's minor, you can just adjust. But if you find that it's dragging for more than half of the cusp width, then you're just going to have to reset the teeth. If there's pain or inflammation on the labial aspect of the lower ridge, if you notice that there's no impression surface defect, you check the insides, there's nothing wrong there. It could be that you don't have enough overjet, and it's causing incisal locking. So as the teeth lock, it's tipping the the denture into that sulcal area, and it's really causing pain and inflammation. So you want to reduce any sort of overlap that you have, and make sure that you either reset the incisors, or you try to balance the occlusion to make sure that that overjet is reduced. So if there's any pain in the periphery or the borders of the dentures, usually accompanied by pain in the masseter or the posterior temporalis muscles, you'd realize the patient is going to say, doc, you know, as the day goes on, the pain just gets worse and worse. And by the time it's time to go to bed, it's just like, oh my God, overbearing pain. Then that's telling you that there's an issue involving the masseter and the posterior temporalis muscles, because the patient is talking and eating during the day. So the more they do those actions, the more that pain increases. So you have an issue with vertical dimension of occlusion, right? So it is too much, and the patient is not able to tolerate it. So you do have to reduce that. However, if you find that it's in less than 1.5 millimeters excess of your vertical dimension of occlusion, then you can just go ahead and do some selective grinding to provide some more freeway space. But if you find it's greater than 1.5 millimeters, you can grind all day. Nothing is going to work. So you're going to have to do a new bite registration, knock the teeth out and do a new bite registration, and reset the teeth at a better video for the patient. Patients complain about cheek and lip biting. Usually that's because the teeth are set a little bit too far buccally, those posterior teeth, and there's the functional width of the sulcus is not restored, so the patient's sulcus is kind of sticking out a little bit. For lips, there's poor lip support, inadequate anterior horizontal overlap, so the lips are getting trapped every time the patient bites. And then usually there's insufficient overjet in anterior and posterior, or the video is too low. So in the case of cheek biting, you want to reduce or smoothen the buccal cusps, or you want to round them. If you find that you're not getting anywhere, the patient is still complaining of biting the cheek, then you may want to reset those teeth more and align with the triangular form of the denture, meaning that the teeth should be set perpendicular right over the ridge, instead of, you know, too buccal or too lingual. Tongue biting, it's usually either lingual overjet or teeth placed a little bit too lingual to the lower ridge, so the tongue is getting trapped as the patient is trying to function, talk, eat, or anything like that. The easiest way is to remove the lingual cusps of the lower teeth, or just reset the teeth. Pain on the posterior aspect of upper denture on opening, you're usually thinking that it's too much in the tuberosity area. It's either too thick or it's too far back, and it's constraining the coronoid process. So when the patient is opening, it's really impacting the patient. So in these, it's a simpler fix. You can just use some PIP paste and just relieve those areas, and make sure you polish those areas back, especially back there, because that movement could really cause that area to get really sore if those polished surfaces aren't smoothened again. So next, we're going to talk about some systemic factors. Okay, maybe your denture, you did everything you can, you try to adjust as much as you can, and you're still having the issue of discomfort. It may not be the denture. It could just be that there's some sort of systemic factor affecting the patient. And we're talking about things like burning mouth syndrome, they just have a beefy red tongue, or B12 or folate deficiency, dry mouth. Patient has a tongue thrusting issue, or empty mouth chewing. We know when we see some of our elderly patients, there's nothing in their mouth, no food, but you see they're like chewing like that. Those are possibly neurological or a psychological factor. So there's not much you can do. if you see herpetiform ulcers, it's not you, it's them, right? It's not the denture, it's herpes simplex. So not denture related. There's not much you can do about that besides making sure that, you know, whatever you could offer the patient to give them some comfort, right? Clicking in the TMJs, it could be a problem that already exists or something with your VDO. If you tried everything and you did the best you can and the clicking is still happening, it's not you, it's them, right? So you deal with the TMJ and not the denture, right? Same with the tenderness to the muscle of mastication. If you're checking everything, you're doing everything that we learned previously in the previous slide, and there's still an issue, you want to try prescribing a muscle relaxer. And if the patient is not complaining after that, then it's the muscles and not the denture. Sometimes you'll have patient coming with a really bad allergic reaction to the denture materials, and that's usually the dentures didn't get heated enough and they left too much residual monomer in the acrylic. So you could either rebase and make sure that the there's a controlled heat cure cycle and all the monomer is really cured out, or try to see if your lab can remake the denture bases with a polycarbonate resin instead of an acrylic. That might be an option, and they tend to not have that much of reaction to them. Some people are just allergic to stuff, right? Angular cheilitis, possible denture-related stomatitis, maybe, or it could just be that the denture is indeed ill-fitting, or it could just be an opportunistic candidal infection, or the patient could have an iron deficiency. So there are many different things that can cause the patient to have discomfort, which is why you want to really look at the patient as a whole, right? Not just the denture, not just the denture surfaces, not just the function of the denture, but, you know, everything else that's going on in the patient's health history could impact how your denture would be post-insertion. So let's get to the most common complaint that patients will say, looseness, right? We saw the picture in the previous one of the earlier slides where the denture remained in the apple the patient was trying to bite, right? The patient is like, Doc, I can't wait to get my teeth. You know, I'm gonna be finally eating some peanuts. You know, I'm finally gonna be chewing on those neck bones, you know, and yeah, I don't think so. Good, you can try, but you know, we can do the best we can to get it as retentive as possible. But here's some of the things that that we could talk about. And if you're still with us and you haven't fallen asleep yet, I know this material can be challenging to digest. I promise after this, I only have about 3 more slides. so we're just going to focus right now on looseness. And usually there are 2 main reasons why dentures can be loose, and it's usually a decrease in retentive forces or an increase in displacement forces, right? So we're going to talk first about decreased retentive forces. So the first complaint or the first issue would be a lack of peripheral seal. So a generalized lack of seal on the denture all around, right? So it could be under extension in the depth or under extension in the width of the flanges, often in the distal buccal aspects of the upper borders of the denture, which may be displaced by the buccinator when the patient opens. So as soon as the patient opens like that, the denture just boop, comes down, or the posterior border of the upper denture, or no palatal seal at all. So what you can do in these instances, add some tracing compound, green stick compound, whatever material you feel more comfortable using. You want to mold it digitally, which means with your fingers, and do some functional movements. You want to pull the cheeks out, make sure the muscle attachments are being registered, pull the lips out, you know, and do some movements, have the patient, you know, do a little bit of movements with their face to make sure you capture what those muscles would need room to do. And then you can have that replaced with some acrylic resin by the lab. Sometimes you can do something temporary with some chairside reline material to see if that works. And if the patient is comfortable, you can send that as is to the lab and they could remake it, replacing the reline that you did, and that will be a much more retentive denture. Also, you want to make sure that the borders are correctly seated on the tissues and between the junction of the mobile tissue and the soft palate. You want to again recreate that posterior palatal seal and get it replaced in the lab with some permanent acrylic resin. So sometimes your patients have inelasticity of their cheek tissues. That is not something that you caused or anything. It's a consequence of aging, or patient has some sort of scleroderma, something like that. Not much you can do, but you can make sure to the best of your ability that you mold the denture borders in small increments to make sure that you're getting as accurate impression as possible. And you want to be slightly, not too much, but slightly underextended in the depth and the width, so that it creates some space as more of that inelasticity happens. So you want to make sure that you're leaving a little bit of room for that patient. Sometimes there's the rocking of the denture because there's air beneath the denture. So when you press here, it falls to the back. When you press this side, it falls to the left, and vice versa. And that's usually if there's some sort of a warpage that happened in the lab. You could have had it perfect up until that point. Honestly, if you're having this issue, you could try to reline it to your heart's content, how much ever you want to. But if it's warped, it's warped. You're just gonna have to remake this denture. Sorry. There's not much you can do in these instances. Let's talk about dry mouth. There's many reasons why patients have dry mouth. It could be some sort of pathology, some blockage, something with the salivary glands, radiation, or they're taking medication. They're over 1,000 medications that cause dry mouth. So you want to make sure that when you design the dentures, you try to maximize retention as much as possible. And then if you want, you could prescribe an artificial saliva where appropriate, but you want to make sure that you're creating enough retention in the denture itself that you don't have to rely on a suitable seal using the saliva. It's going to be difficult and it's not going to be perfect, but at least you can try the best you can by making sure that you're engaging the borders and the movable attachments as much as possible. Then you may have patients with issues who have lack of neuromuscular control, and this will have speech and eating difficulties. Sometimes it's just the patient having a lack of neuromuscular control, but sometimes it's the fact that the denture doesn't have the correct shape. And the lower molars may be too lingual, the occlusal plane may be too high, the upper molars and the buccal to the ridge and the buccal flange not wide enough to accommodate this, or the lingual flange of lower is too convex. Or it could just be that the patient is of advanced age or have issues due to some sort of infirmity with neuromuscular control. If it's just the fact that they have a lack of neuromuscular control, they may not be the best candidate for a complete denture. Or this is where polygrip is going to be your best friend. You're going to squeeze all the polygrip, and hope that it's sticky enough and it holds as much as possible, and to counteract some of the issues the patient has. If not, you can go through all the steps. If your denture shape is incorrect, you can remove the lingual cusp of the posterior teeth. You can flatten the teeth as much as possible, or you can flatten the polished lingual surfaces from the occlusal area all the way to the border, not the occlusal of the teeth, but the occlusal of the polished surface, and make it as flat as possible, to kind of keep the tongue from lifting up the denture and making it a little bit more easy for the patient to chew. When it comes to increased displacing forces, we're going to talk about 4 things, mostly about overextensions. We've talked about overextensions a lot, but based on where it's happening, it can impact a different complaint from your patient, right? So the patient could say, doc, when I'm like just chilling, I'm just sitting doing nothing, the denture just slowly starts rising up, right? And then you notice when you're looking at the denture, looking at the tissues doing a clinical exam, there's this line of inflammation when you reflect the sulcal tissues, or some sort of ulceration right at the base. Like you just notice a line of an ulcer forming right in the junction, and also an ulceration in the posterior palatal seal area. So if buccal to tuberosities, denture displaces on mouth opening, or cheek soreness occurs, thickened lingual flange enables tongue to lift denture, like I just mentioned. What you want to do is you want to under reduce the flange extension and redo your border molding, and then have that remade in the rebased in the denture in the lab. You also want to reduce the posterior palatal seal area until it's a little bit more comfortable, but you also want to have the patient limit wearing it until that inflammation clears up, because you can do as much as you can, but if those sores remain and they keep wearing the denture and recreating that pressure point again, it's just going to stay sore. So you want to make sure that heals up a little bit before you do all this extra work, so that you can have some healthy tissue to be able to reborder your denture. Sometimes the borders are too thick, so the cheeks look right? And sometimes that's because of an increased VDO, so that's a design error. And the best you can do in those states is just use some PIP paste and reduce the overextensions and the over thickness, and just make sure you polish it with the buff after as much as possible, because you're going to be really grinding, or just rebase the denture. Poor fit to supporting tissues, and there's a recoil of displaced tissue, and that lifts the denture. That's usually right from the beginning. There was just not a good impression being taken. Usually in the retromylohyoid area or the lingual pouch area, you either overextended it too far, or you didn't capture it at all. So you want to reline or rebase it. And in those situations, before you take the impression, you want to have the denture off. So you want to tell your patient before you come to the appointment, take your denture off for at least an hour and a half before we get to take that impression, because the pressure that would have left there, the tissues wouldn't have had a chance to recoil. So you're going to take another bad impression, right? And then denture at an optimal space. Well, we didn't make the denture correctly. We didn't follow the triangular form of the denture. We didn't do any of those things. There's some options here in which you can try to correct it bit by bit, but honestly, just remake the denture. If it's not in the optimal place, you're gonna try everything in your power to try to make it fix as much as possible. But if it's just not everything is off, might as well just start over. Or if you have absolutely no choice and you have to use what you have based on the patient's affordability for something new, or your affordability for wiping it off for the patient, wiping it off for your bills and covering it for the patient, then you can try resetting the teeth. Or if you can't reset the teeth, you could remove the lingual cusps and lingual surfaces to restore the triangular form. You could remove the most distal teeth on the denture, and then reshape the lingual polish surfaces. And then you could try thinning out the labial and lingual flanges, or just try resetting the anterior teeth and see if it gets better. So if you don't want to jump straight into remaking the denture, or you can't, just try bit by bit one of these things at a time to see if it helps. And if not, then, well, you will have no choice. So we have 2 more slides to go, so just hold on in there. So when it comes to adaptation, right? You could have done a beautiful job. Your patient, you give the patient the mirror after delivery and they're crying. Oh my gosh, doc. Oh, I love it. I love it. Thank you. I haven't seen myself smile in years and my teeth look so beautiful. Thank you, doc. And then they come back. I hate it. It's terrible. What usually happens is they go home, the husband tells them, "Ooh, why your teeth look like that? They look like chiclets." or the wife tells them, oh, you look like a chipmunk or something. Oh, your teeth look too big, or your teeth too little, or why your gums look so pink, right? And then the patient comes back like in distress, saying, you know, the shade of teeth is too light or too dark or too big or too small. It looks too perfect. Doc, when I was a teenager, I had a space between my front teeth, and you know, I forgot. And when you made it, and I look at myself in the mirror, I don't look like myself. It's too drastic a change. No one teeth look this perfect. Is there a way you can make it look more natural? So in those instances, there's not much you could do besides remaking the denture and listening to the patient and taking a hint for the next denture you do, to try to ask, especially if the patient hasn't worn dentures in a while or has been wearing their old dentures for a long time and they are severely worn, you want to ask for pictures. Hey, do you have any pictures of when you had teeth and that you want me to try to match? Or if they had an old denture and they have they can bring it with them. It could have had like a broken piece or something like that, but you can try to use it as a template for some in some way to get them something that they will be a lot happier with. Because in this instance, it's nothing to do with your technique or how you did the denture. It's really, you just did not capture enough patient information or enough of your patient's needs or enough patient history when it comes to denture wearing. If the patient has creases at the corner of their mouth, you have an inadequate video. So the best you can do is redo your jaw relations and reset the teeth. Speech problems. We hear a lot about this, right? Those of us who remember from dental school, the sibilant sounds, the bilabial sounds, the labiodental sounds, right? Sibilant is the S, right? The bilabial is your P and your B sounds, and then your labiodental sounds, the F and your F, right? Those are the ones where your lips and your teeth contact, right? So typically, if there's an issue with the sibilant sounds, the S sounds, there's an increase in the video, or you have an excessive overbite or overjet. For bilabial sounds, your P's and your B's, something's off with the video. It's too big or too low, right? And there's something off with your incisor position. It could be too forward or too back. Either way, it's not in the right place. And then for your labiodental sounds, same thing. The video is either excessive or not enough, or the upper anteriors are placed too far back, so there's not leaving enough room for that labiodental function to happen, for the F and the V to happen. But also, it could be none of that. It could be the fact that the patient is just not accustomed to the dentures yet, and they have not yet adapted to the prosthesis. Everything you did all the right things. And in these cases, they just need to practice. You want them to do 60 to 66, every day, 10 times a day, 50, 51, 52, peanut butter, banana, over and over until they practice and get more comfortable with these sibilant, bilabial, and labiodental sounds, and really just practicing, and time is your treatment plan here. And obviously, if it's anything to do with the video, you'll check that, and then obviously you'll have to reset the teeth or do a new bite. Nausea and gagging. So usually loose dentures, poor occlusion, thick distal extension, the palatal placement of upper and posteriors, lower occlusal plane, overextended retromylohyoid area, underextended denture borders, psychogenic factors. Believe it or not, some people have a psychological reaction to foreign objects in their body, especially in their mouth, something that's movable. It creates a fear of swallowing it, right? So they refuse to swallow because their mind is telling them that they are going to swallow the whole denture, even though we know that it's not physiologically possible, maybe for a flipper. But for complete upper and lower denture, you're not going to swallow it, but their brains are tricking them into believing that they are going to swallow it. So they consistently gag and just get drooly and they don't want to swallow. So those situations, there's nothing you can do. You can give them a referral to psychiatry to see if there's some sort of intervention that can happen to help them know that the denture is a part of them now. If all other factors are normal, like you don't see any overextension, there's nothing impinging the retromolar hyoid area, it's all good. Everything is good. The video is good. Freeway space is not violated. Everything is fine. Then it's usually a psychological issue. So for those patients, you could, prescribe them something, a sedative while they're using it. But I mean, how they're just going to be, zombified the whole time? I think just send them for a consultation with psych. And if not, then they just may not be a good candidate for removable prosthesis. You may want to consider doing something more fixed for these patients. So those of you who made it to this slide, you made it to the end of a very, very, very tough and mostly boring presentation, but I hope that I presented it as engaging as possible, and I hope that you learned something, and I hope that you were able to take something away. Don't forget, you will have a copy of these slides as well as a great article that outlines a lot of what I talked about today, so that you can go home and regurgitate and really chew on the millions of informations that I just poured out to you today. Thank you very much. If you have any questions, feel free to put it in the chat. Thank you.
Thank you, Dr. Duncan. And you made the presentation very lively, so I'm sure nobody fell asleep. I'm sure everybody was very interested. So I do have some questions for you, and we'll see what else pops up.
Sure.
Let's see. First question is an easy way to remove PIP.
PIP remover. That is the
Yes.
easiest way.
Okay.
PIP remover.
Okay. And so what are the most effective methods for identifying pressure points in dentures?
PIP.
Speaking of.
Yeah, other disclosing materials like Hydent, PIP, again, the snagging dry wool technique. You want to check to see if any pearls or any sharp areas on the denture. Running your finger along the borders, you can feel sharp areas. Those are some of the ways, but usually PIP paste or some sort of a disclosing material will highlight that very, very well.
Absolutely. How could you differentiate between occlusal issues and support problems in the denture fit?
So that is a great question. Oh, hold on. Sorry, my screen has too many things. Usually to differentiate between the occlusal issues and the support problems, you want to ensure that the denture is properly seated in the mouth, right? So if it's as stable as it can be before you check any sort of anything to do with occlusion, because if they aren't seated all the way and it's not stable, it's definitely going to throw off your occlusion. Once seated, you want to check the occlusal contacts using articulating paper. Just make sure when you're taking the dentures in and out, you're doing it, not the patient, because the patient, when they put it in, it could occlude, it could do some pre-occluding. Yes. So you will not be able to know, right? So you want to check for premature contacts once it's stable. If discomfort persists, you even after you followed all the rules of selective grinding, then it's most likely a support problem and not an occlusal problem. Unfortunately, when it comes to dentistry, process of elimination is our best friend, and we tend to have to utilize that until we figure out what it is, so yeah.
Trial and error. So we have a request if you could run through the rules of occlusal adjustment.
Oh, yes. Yes. Okay. Hold on. Let me get that back. Okay. We have enough time, right?
Yes.
Okay.
7 minutes.
Okay. All right, because there was a lot more and I didn't go into everything because I didn't want to use up our time. All right, let's go back to that slide. Okay. All right. So rule number 1, never grind a centric cusp tip unless it contacts prematurely in all excursions in the mandible, right? So we're talking about all of that, right?
Yes.
Always grind the opposing fossa. So all of this is rule number 1, right? That is, if the cusp is in premature contact in centric relation and is also premature in balancing or working, then the cusp should be reduced, right? If the cusp is in premature contact in centric relation, but not in working or balancing prematurely, then the opposing fossa or marginal ridge should be reduced. So when all else fails, and you find something that is an interference, try just adjusting the fossa first, instead of grind the teeth, because the cusp tips, because honestly, once you take it away, you can't really put it back, right? So you want to try to keep as much of the anatomical form as much as possible. So but okay, rule number 2, the bull rule, the BULL rule. So this is you want to grind the lingual inclined plane of the buccal cusps of the upper teeth. So buccal cusp of upper teeth, that's the B and the U. Buccal cusp of upper teeth, or the buccal inclined plane of the lingual cusps of lower teeth. So lingual cusps of lower teeth is the LL. So the BULL is buccal cusps, so of the upper teeth, or the lingual cusps of the lower teeth is what you want to adjust. Okay. Number 3 is that if there is a premature contact on the balancing side, then you want to adjust the buccal inclined plane of the lingual cusps of the upper teeth, or the lingual inclined plane of the buccal cusps of the lower teeth. If you're trying to grind, just remember, never grind the interfering cusp tips, but grind the cusp inclines, right? So not the tips, the inclines, because that is what's causing those interferences, the inclines, not the cusp tips. And I think that was number 3. Number 4 is if you're correcting protrusive interference in the anterior teeth, you want to reduce the distal slopes of the upper buccal cusps, or mesial slopes of the lower lingual cusps. So selective grinding of balanced lingualized occlusion is similar to a fully balanced occlusion, with exception that only the lingual cusps of the maxillary teeth or the antagonist, the opposing teeth surfaces, are adjusted. Selective grinding of non-anatomic teeth, if you have like teeth that are monoplane occlusion, you want to make sure that you take a lot of care to maintain the occlusal surfaces to the mandibular arch, and the occlusal surfaces of the maxillary posterior teeth. You want to make sure that they're not altered, and to create just no balance at all. All right. So again, the bull rule, you can just write down BULL rule. You can Google that for some more. Try to grind the fossa instead of cusp tip as much as possible. If you don't remember anything else, grind the fossas, not the cusp tip. And always try to grind the lingual aspects, or the lingual aspects of the upper anterior teeth, and the buccal aspects of the lower anterior teeth, if you have any protrusive interferences, and not the actual top of the incisal edge, just that angle right in front. All right.
Very good.
Hopefully I didn't confuse you more.
Uh,
It is a very fun topic.
Couple more questions.
Sure.
Do you know of a powder adhesive for dentures besides Fixodent or Polygrip, which tend to come in a cream?
Good question. I do not, but I can look it up and we could set it out to you guys if I find something, but not that I know of.
The last question is, could you mention again, I guess, what causes the clacking sound? So I'm not sure if she meant the TMJ or the dentures
I think
clacking.
she's talking about when the dentures were clacking. I think that was that would have been in the discomfort. Let me find it. Give me 1 second. scrolling through. So not the clicking, but the clacking, right?
Yes.
I think that was under looseness
Yes.
somewhere. Let me see. Cheeks recoil. I think I went too far back. Mirak. That's TMJ pain. Obviously, my brain isn't reminding me. Pain on the. If I can't find it, you will get this PowerPoint, and it's in there in some of these words here. I just can't remember. But I think that has to do with the looseness and the lack of seal. And that's because your dentures are either rocking or there's some air below the denture, and that is usually not much that you can do to fix that. Really, that is usually if it's warped, and that's usually occurs in the lab stage when they're casting it, the casket have broken, or it was too much heat and the dentures kind of, the acrylic warped a little bit, and there's air under there and it's causing some clacking, as well as that can happen during with the elasticity of the inelasticity of the tissues that can also cause clacking. I'm trying to remember where I had that. Usually, I think that was under, maybe I talked about it more under speech. Um, but don't worry, I'll find it. If I didn't cover it fully today, I can always, follow up. You have my email, jayduncan@zufallhealth.org, and I can give you a little bit more detail if this was not enough.
Thank you so much, Dr. Duncan. It was a pleasure to have you as part of our CDE series. More CDE courses will be announced soon. We encourage you to visit our CDE alerts link to sign up for notifications about other future courses if you have not already done so. As a reminder, you must take our survey to get credit for tonight's course at zufallhealth.org/CDE. Thank you again for your attention and have a great evening.